So the bleomycin model of lung fibrosis, as I said, we've heard a lot about that over the last few days, and I'd argue, and I think we'd all agree, that there's no such thing as the bleomycin model, given that everybody uses a variety of different routes of administration, different doses and different species. Now the model we tend to use is the oropharyngeal route of administration, and as you all appreciate, the fibrosis develops within a few weeks. And using what we consider to be the gold standard of HPLC analysis of lung collagen, we only really see a doubling in the amount of total lung collagen, so it's quite a blunt readout. But it is a rapid and well-characterized model, and you could argue that the insult is clinically relevant. But as we've all heard, there are a number of limitations. It isn't a model of IPF. There is no model of IPF. It can be highly inflammatory. There are fibrotic lesions, which you can see here, but there aren't any typical fibroblastic foci. And the fibrosis may or may not be self-limiting or resolving. And I should also point out that, as I said, this is a blunt readout of the fibrosis, but equally histology can be prone to problems as well. And both of these sections are actually taken from the same mouse. This one is a lower level section and this is a higher level section, just highlighting that there's a sort of inherent selection bias when you're trying to do histology. So we wondered whether using micro-CT might provide us with a more reliable endpoint measure that would be beneficial over and above hydroxyproline. And we actually chose to go down the route of using ex vivo micro-CT instead and see if we can use that as a tool for preclinical drug evaluation. So our aims were to, rather boringly, fully reinvestigate the natural history of our own model and then compare the ex vivo micro-CT with our classical endpoint measure of hydroxyproline and see whether we could use micro-CT to benchmark a therapeutic dosing regimen. Now, Victor's talk very, very nicely alluded to all this already, and I was pleased to see that he used exactly the same strategy. But we went back to basics, and having used the oropharyngeal route for several years, we realised we'd never actually done a full-time course of the fibrotic response. So that's what we did. And no great surprise is that the fibrosis develops within around 14 days post-bleomycin. There's not very much going on before that. But if you go from 14 days out to 28 days, that's when you see what we consider to be fibrotic progression. So the fibrotic lesions are already established at 14 days, and the fibrosis worsens, at least in terms of lung collagen, if you take it out to 28 days. Now, what you'll appreciate on the right-hand side of this graph is that when we took this out to 84 days or 3 months post-bleomycin, we really didn't see any resolution at all. So the increase in lung collagen at 84 days was still roughly double that of the saline animals. So again, coming back to the question that Victor just posed before about resolution. And these are young mice. So what about micro-CT analysis? Well, there are several people in this room who use this approach, and it's increasingly used for in vivo animal imaging and longitudinal studies, which is great, but it does have its practical limitations in that setting. On the right here, you can just see some in vivo images from a paper by Rutt et al. From 2010. And you do get these nice in vivo images, but the resolution is somewhat constrained. There are, in fact, very few studies using micro-CT for ex vivo analysis. So that's what we did. We used a voxel resolution of around 13 microns, and then used some pattern recognition software to work out a composite measure of volume and density. So how do these lungs look? Hopefully over here you can see a saline-treated animal, and we do get very nice high-resolution CTs of these things. You can see it's pretty normal, and you can see the large airways. And if you go through the fibrotic response, I hope you can appreciate these fibrotic lesions which pick up. And a consultant radiologist at University College Hospital helped me interpret these, and we decided there was good evidence of dense consolidation, traction bronchiectasis, subpleural thickening, and a sort of interlobular reticular network of fibrosis as well. And I hope you can see that by 28 days, the lung outline is also becoming a little bit distorted. Now, if we look at our 3-month post-bleomycin animals, the fibrosis is still pretty self-evident, really. Still lots of dense consolidation, traction bronchiectasis, and I hope you can see that the lung outline is becoming even more distorted with this sort of reticular network of fibrotic fibres. Now, we had a few mice left over, so we thought, all right, we'll just leave them a bit longer, and took them out to 6 months post-bleomycin. And again, we still saw these fibrotic lesions. The lungs were even more distorted, with lots of scar tissue contracting the surface of the lung, and these dense fibrotic lesions. And the 3 to 6 month post-bleo window, the radiologist figured looked a little bit more like fibrotic organising pneumonia. And this is just a 3D reconstruction of a saline-treated animal, just so you can get an appreciation of what a normal lung looks like. This is the dorsal side that's just spun round, and we're coming round to the ventral side. So that's what a normal lung looks like. This, on the other hand, is a 3D reconstruction of a bleo lung 28 days post-bleo. And I hope you can appreciate the dense fibrotic lesions on the dorsal surface. They do extend through to the ventral side, and they tend to be in the sort of mid to upper lung, but in all of the lobes. Whee. And the astute among you might notice that the heart is missing. I took that out because it made the images easier. Okay, so what about our therapeutic intervention? We didn't want to reinvent the wheel on this one, so we decided to go in for the daddy of the cytokines and block TGF-beta signaling. So we used an ALK5 TGF-beta receptor kinase inhibitor to block the downstream signaling of TGF-beta in that window from day 14 to day 28, where we know that there is fibrotic progression. And just to reiterate this CT issue, here's a coronal section of one of our CT lungs, and you can see the lesions on the CT really do correspond perfectly with the histological fibrosis that you see on lungs processed subsequently. And the really dense lesions on CT correspond to bands of scar tissue running through those lungs. And what we did was apply a tissue segmentation analysis approach to these lungs. And you can see the fibrotic regions here and the normal regions were segmented. And that allowed us to generate a volume of fibrosis and its associated density to give a sort of composite measure of the volume and density of fibrosis. So how did it match up? On the left, you can see that our intervention was successful. We had around 50 to 60% attenuation of the fibrotic response as measured by our gold standard HPLC. But as I pointed out, it's a really blunt measure. There's only a sort of twofold increase in that measure. On micro-CT, however, we had around a tenfold increase in our volume density measurement. The attenuation was pretty much the same, 50 to 60%, but the two things corresponded very well. But we were hopeful that with this sort of window, if we were going in with a drug that might be less effective than the ALK5 inhibitor, we would still be able to detect a difference which we might miss using HPLC. And importantly, as a sort of refinement of the model, this only needed 3 or 4 mice per group as opposed to around 10 mice per group for HPLC. So we applied the same thing to the persistent fibrosis question, and I hope you can appreciate over here that 3 months post bleomycin, there's still a massive increase in the volume and density of fibrosis in these mice. And even by 6 months, there is a significant increase in that fibrosis. There is some diminution here, and what we think is that actually represents a decrease in the cellularity of the lesions, but what is left behind is this very dense fibrotic network, which really does obliterate the lung, and I think you can see that on a 3D reconstruction here, this sort of lace-like network of fibrosis running through a lung 6 months post-bleo. And just to show a little bit of histology from 3 months post-bleo, another feature that's worth pointing out. This is a histological section that corresponds to this little bit of the lung here. And one thing I hope you can see is that there is plenty of what we would consider hyperplastic epithelium. We also get bronchialization. There's lymphoid aggregates and these dense bands of scar tissue that run through the lung. Okay, so just to conclude, what we've done, although it's rather boring, was to go back and confirm where we had a window for doing true therapeutic dosing in our model, which I think is something that's very important to do if you want to know that you are therapeutically dosing. And we found that the ex vivo micro-CT really did give us a fantastic window for detecting those fibrotic changes. It gave very nice high-resolution imagery. It was highly sensitive and robust measure, which we've benchmarked against HPLC. It needed fewer mice per group, which is rather handy too. And following on to this resolution question, we really saw that after a single dose of bleomycin, we didn't see what you would consider full resolution at all, which is perhaps something we can discuss. And I'll just acknowledge the people who are involved with this. Obviously, the director of our centre, Professor Rachel Chambers, my 2 PhD students, Robert and Arnie, over here, who were volunteered to do all of the ALK5 dosing. Dr. Penny Shaw at University College Hospital, consultant radiologist, who helped me interpret the CTs. And none of this would have happened without our external collaborators up at GSK, particularly Brian Hayes, who were instrumental in really getting this CT approach set up. And I'll just leave you with one more little video, which something you may never have seen, which is just a virtual bronchoscopy of a 6-month post-bleo lung. And I'm happy to take any questions.
Start if I may. Did you do any compliance studies on the mice? It'd be interesting to look at the physiology as it over time. And
yeah, it would be fantastic to do that. So one thing about the ex vivo micro-CT, obviously it's ex vivo, so right. And the lungs are processed as if for histology, so they're fixed and insufflated and so on, so you can't do any compliance.
Yeah. So that was really beautiful talk. Thank you. And I'm really struggling to understand the differences among laboratories, because we did exactly the same experiments, and we've done them in 8 different strains of mice, and we find just the same thing, that there's we didn't go up to 6 months, we only went up to 3 months, but up to 3 months of age. There are some differences in the rate of resolution among different genetic backgrounds, but in every genetic background we looked at, there's still substantial residual collagen present months after the administration of bleomycin. We did the experiments because Kamran Atabay wanted to study resolution and thought we would be able to see complete resolution in some strains of mice, but we never did. So I don't understand exactly what it is about other laboratories that they see complete resolution. And we didn't give it oropharyngeally, we give it intratracheally.
Intratracheally, yeah. Well, perhaps we should go out on a limb. Put your hands up if you use bleo. Put your hands up if you see resolution. Well, okay, so that was sort of 30% of the room see resolution. Yeah, partial resolution. So that's the thing. I mean, one question, obviously, which Victor and I talked about. Yeah, well, lack of progression.
Yeah, exactly.
But maybe this idea that the lung completely resolves is something that has become dogma in this model, perhaps is inappropriate. But as Victor and I discussed yesterday, what do we mean by resolution? Do we mean anatomical resolution, physiological resolution, functional resolution? So something to bear in mind.
Chris, thanks a lot. Nice movie, a nice talk. I have a question. I think the question had been raised at the beginning. So did you have a chance to look for lung function parameters?
No, so it's not something we've done.
Adaptation or something over the long time course?
Yeah, we would absolutely love to do that. And if somebody wants to lend us some flex event, we'll happily do that. But we haven't done it yet.
And one small second question, because I think I missed it in the talk. So when did you give the inhibitor? Also in a very early time point, or also at the later time point?
No, only dosed from 14 days. So once we know we've got established fibrosis. And you'll see that we didn't get full resolution or full attenuation of the fibrosis. I think we've just stopped the progression.
I was just wondering, it would be interesting if you have the later time points where you still have fibrosis and then go in if you see a different response, probably, in other pathways.
Quite possibly.
Yeah, sorry. No, I will give my voice for the next talk, sorry.
Brilliant.
Luis?
All right. No,
briefly?
All right. So briefly, a comment to Dean's, which is that, remember, bleo is a very complicated drug. It is made batch by batch. And there has been an enormous difficulties homogenizing that. If you go back to the work of John Laso, who is the only person that I know had actually done chromatography to assure that you got the exact percent of this amidobleomycin, because other than that, what you put in there is metabolized in the liver. Remember that the half-life of bleo in the lung is less than 32 minutes. So endotracheal bleomycin is not a good model of pulmonary fibrosis. The work that John Laso did was to put it in an ALSA pump in the peritoneum and infuse it over 14 to 21 days. And based on that work, we subsequently took over, and then it's just too cost effective to put it in the airway. It's just a comment, but I want you to consider that.
Well, I think that's fair enough. And as I alluded to in my first slide, everybody uses different dosing regimens, different routes of administration. And
And
it makes a big
that
difference.
has a human correlate, because those of you who have seen patients that had bleomycin-induced lung injury realize it's not coming back. It has inflammation, but it's a fibrotic lung injury.
Very nice talk, and I was struck by your observation that there was a decrease in cellularity later on. And I think, and I'm just going to suggest that perhaps some of the differences in observations from across labs may be due to the manner of expressing the data, how to normalize the data, collagen per what? Per gram, per DNA, per total left lung. That may also explain, in addition to Luis's comment, some of the variability between labs.
Yeah, well, we always do collagen as the total lung, so we don't separate off lobes in case there's any heterogeneity in where the hit has gone. So this is all 5 lobes of the lung, so it's the total lung collagen.
Thank you.
But it's a fair point.
Excellent talk. We're starting to see human data with CTs that we can see changes longitudinally over time, quantitatively. My question is, I appreciate the ex vivo model of this, but how good of images can you get in vivo where you might be able to follow the same animals over time and see how they respond to a therapeutic as opposed to potential sampling errors with different animals at different times?
Yep, absolutely. So obviously the in vivo longitudinal idea would be great, but you do need a specialist setup for that. And there are limits to the amount of radiation that you can give to the animals and so on. But I mean, there are people in this room, Katil Ask is here, I think, and Martin Kolb, those guys have done longitudinal scanning with in vivo CT. The issue is that the resolution you get down to is around 30 or 40 micron voxels, as opposed to 10 or 12, which we're doing. But it does work, and you can do nice pattern recognition, but you do need a specialist animal setup. This you can open up to collaborative applications. So, we've been CT scanning lungs from other labs, for example, which you can't do with live animals.
Oh, one more.
Sorry, Darryl.
Sorry, Chris. How are your lungs fixed?
So this is standard histological fixation. So they're insufflated and fixed with PFA, paraformaldehyde, and then processed as if for histology.
So I'm wondering.
And then we use them for histology afterwards.
Yeah. So I was wondering if you can modify it, like just inflation fix in fumes of liquid nitrogen or something. Then you can actually go back and pull out those areas that are fibrotic and do gene expression profiling and try and dissect out the processes that way.
It'd be nice. We haven't tried it, but it'd be lovely to be able to do that.
Well, Jim Hogg's lab does it with bits of human lungs, so it'd be worthwhile getting their method. I think you can actually really get some very useful information out of it.
Yeah, fantastic.
We're having some great discussion, but we do need to move along. Thank you very much.